My name is Faisal Syed. I'm the National Director of Primary Care at ChenMed. I'm joined today by Dr. Daniel McCarter, who's our National Director of Primary Care Advancement and also Associate Professor of Family Medicine with the UVA School of Medicine. I'm here with you today to talk about value-based care because as the country is debating how to make the transition from the current model, which is fee-for-service, towards value-based care, I think it's important for you to see how an organization like ours, where a private family-run organization that started 35 years ago, is actually already scaling out not only value-based care, but full risk value-based care. Yeah, I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's life? Will is saying that human life is priceless, which is to say without any monetary value. I can safely say that the current fee-for-service system, healthcare is rationed out based on the patient's ability to pay. It's very painful to see that in the fee-for-service model, which is the model 95% of the country is still functioning in the fee-for-service model. Based on the level of insurance a person has, that's the access to care that they end up having. So if you have obviously someone who's unfunded or someone who doesn't have health insurance, their options are much more limited than someone who has very, very good insurance. Everyone should be treated the same, regardless of their ability to pay. Everyone should have access to quality medical care or primary care, regardless of their ability to pay. And in the fee-for-service system, I hope you all understand that is not happening. Half of all medical care in America right now is delivered in the emergency department. Just imagine that. And that's because the incentive, I believe that one of the main reasons for that is that the incentive is to generate revenue or make profits over stabilizing or improving health. And Dr. Dan presented how to successfully scale out a full risk value-based care practice. In fact, we were the only ones that day presenting value-based care. And it was an incredible eye-opening experience for me to see that many know that we need to move in this direction, but they're still debating how to make the transition from fee-for-service to value-based care. And so last year, we presented value-based care at 49 residency programs. And we were surprised to see that many residency programs, internal medicine, family medicine, and also geriatrics fellowships, were not investing time educating residents on value-based care. So ChenMed is a private, family-run primary care center that focuses on geriatrics care. Is now 35 years old. This year, ChenMed is 35 years old. The CEO of ChenMed is a physician. And we believe to make the transition from fee-for-service to value-based care that it needs to be physician-led. Value-based care is something that can be scaled out all over the country. We're currently in 10 states. 35 years ago, of course, we started in one state, started in Miami, Florida. We're a purpose-driven organization. We're heavily invested in educating our physicians to be future leaders. We have an aggressive training program, what we call our Black Belt training program, that allows physicians to learn some of the core metrics, what we believe would make them successful in being independent. We believe that you can give VIP care, which is where you honor seniors in a manner that is affordable and makes sense. We currently have over 60 primary care centers across the country. We take full risk for Medicare Advantage and dual eligible members in multiple plans. Our patient population, we focus on the poor, the sick, or the medically complex, and the elderly. Our average patient is between 72 and 74 years old. And many of my patients were earning somewhere between $600 to $900 a month in Social Security. So these are patients who are on Medicare. And we open our centers specifically in the poorest neighborhoods, the areas of most need.
I would say the other thing about the old, the poor, and the sick is we can offer so many more services to them than they could get from traditional Medicare.
We do have some patients who are under the age of 65 who are dual eligible. They have Medicare because of a physical or psychiatric disability. So per capita spending We spend about twice as much as any other developed country, but yet, so far as health outcomes are concerned, we're some of the lowest. The creation of value for patients should determine the rewards for all other actors in the system. Value in healthcare is measured by the outcomes achieved, not by the volume of services delivered. This is a fundamental concept in value-based care, which is differing obviously from the fee-for-service world. Dr. Dan, I would love for you to tell the example of your son for this slide.
So when my son was in college, he had my credit card in his pocket. And the only thing that kept me from buying him and all of these friends every weekend was the relationship I had with him. He had it for emergencies. So every one of our patients are walking around with their insurance card in their pocket. And the only thing that stops them from dropping in at any emergency room they want to and spending $1,500 or more of our money is the relationship that we have with them.
Thank you. In the fee-for-service world, if you need to make more money, you need to run faster or do more procedures or see more patients. Basically, each encounter, there's a fee that is associated with each encounter and a fee that is associated with each procedure. In the value-based care world, if you need to make more money, you need to think more and reduce hospital admissions. So when the patients do well, then you're able to make more money. So we spend about $3.9 trillion a year as a country on healthcare. And in October, it came out that we now have crossed the $1 trillion mark so far as medical waste is concerned. So the three leading causes of medical waste in the country, number one, is unnecessary hospitalizations. Third leading cause of death in the country being medical error. So you literally have a 1 in 200 chance risk of dying from a hospital-acquired infection on admission, and the risk of dying from a skydiving accident, 1 in 2,000.
Now, the thing you got to remember with that risk of hospital-acquired conditions, our patients have 5 or more chronic medical conditions. There's a good chance they show up in the emergency room, they're going to get admitted to the hospital, and now we're exposing them to that risk of 1 in 200 of having a hospital-acquired condition and dying from that.
Number two is unnecessary referrals to specialists or ordering specialty imaging tests. And number three is the use of brand name medications when there's a generic equivalent that's available. If you had 10 patients that we received for admission, 1 to 2 of them didn't need to be admitted. And many of them were stabilized by the time it came to us for the admission. And maybe those patients, there'd be a number of them that we would admit just for a 23-hour observation. And the average admission, depending on what part of the country you're in, costs anywhere between $10,000 to $15,000. I had no idea